Guys. So I'm going to continue on with our chapter 22. Be kind of weird, be kind of hokey. There's a couple of short slides here, but we're going to go through it. EMR patient assessment, musculoskeletal injury, how we're going to assess these patients. We're basically going to be identifying, possible fractures, possible strains, sprains, always assuming that any injury to an extremity is a fracture. Assessment of musculoskeletal injuries. Typical findings, what we're going to see, just simply pain, people that have pain. And please know something, sometimes the pain is not extremely bad. It's not crazy bad, okay? My son is kind of funny. He was in school. Someone had kicked a soccer ball, and he had reached out with his hand to catch it when they kicked the ball. Well, when he reached out, it hit him perfect in the palm of the hand. His hand bent backwards. And he said, "Oh, that hurt, no big deal." Walked away and finished off his day. I mean, went to class, was writing, everything. Had a little bit of ache, no big deal. 3 days later, when you say it still hurts, it just doesn't, he's having a little bit of trouble moving it. So I had to take him to the ER thinking, he's fine, just sprained it or something. Sure enough, it was fractured. So pain, while we're thinking breaks, severe fractures can be painful. Sometimes it can be kind of just nagging, basically nagging. Tenderness, deformity, open wounds, crepitus, loss of range of motion, swelling and discoloration, loss of sensation, and loss of circulation. All of these things are things we'll be looking for to identify that we have a possible musculoskeletal injury. How do we care for these? Again, once we've identified it, we're going to stabilize it. Okay, this is making sure that it doesn't move any further anymore. We're going to immobilize the injury. And the first part is just to stabilize it with your hands. Treat life-threatening injuries first, always. Consider manual stabilization of the spine if that's needed. If there was a traumatic injury that may have caused spinal injury, remember anything blunt force trauma, clavicles, and above, we're going to need to worry about C-spine. Manually stabilize the site, expose, treat open wounds, assess circulation, sensation, and motor function, apply cold packs or ice, allow position of comfort. Principles of splinting. And I think we're going to stop. Well, let's go. So basically, again, we're stabilizing the injury, okay, to manage it. Reasons we need a splint: stopping bone ends from damaging tissue, managing pain, controlling any bleeding that might happen, and preventing circulation and nerve damage. Some rules we need to understand: communicate with the patient always. Everything we do is communication with the patient. Maintain manual immobilization, expose, dress open wounds, straighten angulations. Straighten angulations. If we can, sometimes it may not be something that's really feasible, but we could. Assess circulation, sensation, and motor. This is the PMS I think we've done before in the extremity. Okay, first things first, pulse. I squeeze the nail bed. The color should return within less than 3 seconds. The next thing is motor, which is asking them to move their fingers. The last thing is sensation, ask them to look away before you touch, so you can tell they still have connection from their brain to their fingertips or toes, whatever it might be. Consider padding to fill any void space. So mobilize above and below the injury, and you want to reassess this injury is every 15 minutes, just to make sure that things are actually working the way they're supposed to be. Okay, we're going to stop there. We'll talk about splinting another time. And this will be kind of interesting because I'm going to have you guys do a little something at home as well. So that takes care of that. We're closing in, guys. I know this is really hokey, but we're doing the best we can, okay? Guys, take it easy. Bye.